So hemorrhoids is a term that is used by lots of people and means different things to different people. So to a patient, hemorrhoids means anything that afflicts their back passage, be it discomfort, swellings, or bleeding from the back passage. Whereas to a consultant colorectal surgeon, hemorrhoids is a very specific term that refers to cushions of tissue which are both covered with skin and lined with the lining of the bowel that can cause mischief in and around the back passage. The main symptoms of hemorrhoids are bleeding and the presence of a lump. And in fact, hemorrhoids normally are not a painful thing to have. They just feel uncomfortable and bleed, as I referred to. So if a patient has a pain when they open their bowels, it's much more likely to be due to another common anal condition, which is known as an anal fissure. And an anal fissure is an ulcer in the back passage, which gets aggravated every time the patient opens their bowels. And classically, patients can describe being in pain for several hours after defecation. So going back to hemorrhoids, they occur in varying degrees. So you can just have internal hemorrhoids without any external signs at all. And they present themselves by the production of bright red blood on opening the bowels, or bright red blood when the patient wipes their bottom. And obviously it's very important in any patient who has bleeding from their back passage to exclude the possibility of more sinister pathology, such as bowel cancer. And the way that that's normally done is by assessing the patient and possibly referring them for further investigations, such as colonoscopy or virtual colonoscopy or other similar investigations. In fact, in the United Kingdom, everyone aged 60 is sent a bowel cancer screening test through the post, where by putting a smear of fecal matter on the test provided, they can tell whether there is blood in the feces or not, and then organise investigation as appropriate. Going back to hemorrhoids again, so hemorrhoids that just bleed, I normally spend a lot of time reassuring patients that there are quite a lot of people out there who have a little bit of blood when they wipe themselves, and that simple measures such as increasing the amount of fibre in your diet and the amount of water that you drink can ameliorate these, because it makes the stool softer and less likely to aggravate when opening the bowels. If the bleeding is substantial or more worrisome, these patients can require further treatment. And prior to further treatment, we examine our patients both with a finger and with a little instrument called a proctoscope, through which you can see the degree, size, shape, and anatomy of the hemorrhoids. So for people with small internal hemorrhoids, there are what surgeons refer to as office procedures, which, whilst it is an Americanism, beautifully describes the treatment which is carried out in the consulting room or office of the consultant. And different surgeons have different favourite techniques for this. For me personally, I inject hemorrhoids with a substance called oily phenol, which causes them to shrivel up with time. But I have colleagues who will use rubber bands which are placed over the hemorrhoids and sort of throttle them off. And there are a few other more modern treatments which can be used in the office that involve devices that burn, freeze, or fry the hemorrhoids. In my own practice, I will normally only do injections, and anything else I will want to do as a procedure in the very secure and safe surroundings of an endoscopy suite or an operating room. So in a patient who has bigger hemorrhoids, ones that prolapse when they go to the toilet and they have to push them back in, or ones that are hanging out all the time that are covered with skin, in my mind, the finest treatment for these is a very traditional treatment, which is called a hemorrhoidectomy, and essentially consists of putting the patients to sleep and then excising or cutting the hemorrhoids off. This is a very effective treatment with great outcomes, but it is a very unpleasant process to go through. And I warn my patients that they will dislike me intensely for 2 weeks after this procedure, and that the wounds can weep until they heal over a period of about 6 to 8 weeks. But once the process is over, the end results are very good. And I reserve this operation for people who are deeply troubled by their hemorrhoids, and for patients who have as I say, hemorrhoids that prolapse or are prolapsed all the time or are covered with skin. In terms of lesser procedures for hemorrhoids, there is a whole battery of operations that have come over the last 10 years, which range from a mechanism for placing a suture under the artery that feeds the hemorrhoid under ultrasound guidance. And there are two systems for doing this hemorrhoidal artery ligation procedure available. And the other one that has become available recently is called Raffalo, and that involves inserting a needle into the hemorrhoid through which radiofrequency is applied that ablates the hemorrhoid and causes it to necrose in the week or two after the operation. And again, these procedures I personally do under a short general anaesthetic, but I do have colleagues who are happy to do them in the endoscopy suite with some sedation. Finally, there is an operation which I've been doing for many years, which is known as a stapled hemorrhoidectomy, which involves a device that is deployed within the anal canal that excises a centimetre of the lining of the back passage and then clips it together. And this device is very useful in patients who have substantial circumferential hemorrhoids, as it treats them all in one go. This operation normally is only done in centres which have experience of it and in very specific cases. So just to summarise, I'm very happy to treat patients in my office for their hemorrhoids, and I personally use injection, but I have colleagues that do other techniques. And in my hands, and after many, many years of treating hemorrhoids, the finest way to treat them, if they are very troublesome, is with a formal hemorrhoidectomy, though I am happy to deploy the other devices that I've alluded to in appropriate patients. And the key here is for the patient to listen to their surgeon, who will offer them the various options and decide whether they feel that it is worthy of going through a probably unpleasant process in order to deal with the hemorrhoids, or whether they wish to live with them and merely adopt conservative measures such as diet and fluids. So the answer is that sitting habits probably won't make any difference to your hemorrhoids. It is thought that sometimes hemorrhoids can be made worse by straining on the toilet for long periods of time or sitting on the toilet for long periods of time. And therefore there's the concept that you should drop your stools and get up and go as quickly as you can to avoid exacerbating or causing hemorrhoids. In terms of diet, again, it is thought that the straining to pass hard stools can be involved in the process of hemorrhoid formation, and therefore keeping your stools soft by drinking a lot of fluid and taking some fruit and fibre in your diet should make them better. Those are the traditional concepts in terms of diet. I think sitting on its own or sitting at a computer for long periods of time will have no effect on hemorrhoidal disease. I think any patient who has bleeding from their back passage should consult their doctor, particularly patients later in life, as this can be a manifestation of a more significant pathology. So in particular, if they have bleeding that is dark red in nature, and in particular if their symptoms are associated with a change in the bowel habit, say between diarrhea alternating with constipation or some marked change in bowel habit. With regard to actual hemorrhoids, I think if they are troublesome and they bother you, then it's worth going to see a doctor, and it's worth getting an opinion on, firstly, that it is actually hemorrhoids that is the source of the trouble, and then to be offered either conservative treatment or advice to leave them alone versus one of the procedures or operations that is available to treat hemorrhoids. And then between the doctor and the patient, a decision can be made as to what is the best thing for that bespoke particular patient and their hemorrhoids. So doctors treat hemorrhoids in a variety of ways, which I've alluded to in my previous videos, and it's a very interesting question. So most doctors or most colorectal surgeons have their own preferred way of treating hemorrhoids, and they will discuss their preferred technique for your particular type of hemorrhoids with you. And then my advice to patients is they really have to think carefully how troubled they are versus what is actually required to treat their hemorrhoids in terms of the potential suffering during the process post-treatment. And I think that's a conversation that has to be had very carefully between the patient and their physician, so that that patient's individual circumstances can be absolutely taken into account, such that a decision can be made.